Yeah, g'day guys. My name's Josh, one of the emergency department registered nurses working in Canberra Hospital ED. And today just going to do a quick presentation about an elderly gentleman, Mr. Smith. So Mr. Smith is a elderly male who's presented to my emergency department with acute confusion and fever. I've recorded his blood pressure at 90/40, and my concern is that my patient is septic. Now, what I've been asked to present to you today is to determine the mean arterial pressure and describe the process of interpretation that I've used, my diagnosis from the history and the map, and to recommend emergency management. To start with, what is MAP? Mean arterial pressure, or MAP, is the average pressure in a patient's arteries through a complete cardiac cycle. It is considered a better indicator of overall tissue and organ perfusion than systolic blood pressure alone. As you can see on the screen, MAP is calculated through the formula of the diastolic blood pressure times 2 plus the systolic pressure, then divide by 3. Now, since 2/3 of the cardiac cycle is spent in diastole, it accounts for twice as much as the systolic blood pressure in MAP, thus why we times the diastolic blood pressure by 2. In our case study with Mr. Smith, whose blood pressure is 90/40, we can figure out his MAP. So his diastolic blood pressure, 40 times 280, plus his systolic blood pressure of 90, which gives us a total of 170. Divide that by 3 and you get 56.6. Now, a normal MAP range for an adult is somewhere between 70 to 100, and the body requires a minimum MAP of 60 to maintain adequate tissue perfusion to the organs. As such, we can see that Mr. Smith is suffering from a profound hypotension. Now, unfortunately, we've not been given a full assessment and history regarding the presentation of Mr. Smith, thus making a definite diagnosis extremely difficult. But what we do know about Mr. Smith is that he's presented with a fever. He's presented with an acute confusion, hypotension. One of the possible diagnoses that was initially flagged in the introduction was sepsis. Now, fortunately, the definition of sepsis has only recently changed, with a third international consensus definitions for sepsis and septic shock, otherwise known as sepsis 3, being released last year in 2016 by the Journal of the American Medical Association. Now, this is important because our previous definition of sepsis hadn't been updated since 2001, and this is despite considerable advances in our understanding and treatment of sepsis. Now, Sepsis 3 was developed by a collaborative group of critical care, infectious disease, surgical, and respiratory specialists. And their new definition, they came together after several meetings, and was a life-threatening organ dysfunction caused by a dysregulated host response to infection. Now, that's just a very wordy way of saying that sepsis is the body's response to an infection which causes injury to its own tissues and organs. To clinically diagnose a patient with sepsis, the patient must have a suspected or confirmed infection. Also must have a change in their sepsis-related organ failure assessment score, otherwise known as SOFA, of 2 or more. Now, this is the table that encapsulates the SOFA score. And you're looking at things such as blood results, whether they're needing inotropes, urine output. Unfortunately, it's something that's going to be done in an intensive care setting or well after initial treatment in an emergency department should have been commenced. Now, as such, the committee also ratified the use of the quick SOFA or QSOFA which looks at a set of specific criteria for diagnosing sepsis in a non-ICU setting. Important to note though, the QSOFA does not define or diagnose sepsis. It merely identifies patients who have a higher mortality and whom sepsis treatment protocols should begin on. Now, like a normal SOFA score, a patient must have a suspected or confirmed infection. The patient must also have a QSOFA score of equal to or greater than 2, and that is scored by the patient being hypotensive, which is defined as a systolic blood pressure of less than 100, having an altered mental state, which is having a GTS of less than 15, and being tachypneic, which is also defined as having a rest rate of greater than 22. In our case study here, Mr. Smith does have a fever, thus it's reasonable to suspect that he does have an infection of some degree. And Mr. Smith scores a QSOFA of 2, 1 for his hypotension with his current blood pressure of 90/40. And Mr. Smith also does have an altered mental state with his acute confusion. Now, given this information, it would be reasonable to have a provisional diagnosis of sepsis being made until a full SOFA score can be completed, and for Mr. Smith to be put on the appropriate sepsis pathway. Unfortunately, specific treatment protocols for sepsis vary in emergency departments throughout the nation, and there is no one standard protocol being used nationally. For example, New South Wales Health is currently using the Sepsis Kills protocol, while other centres are using the internationally recognised Surviving Sepsis campaign, which released new treatment guidelines in 2016. The Surviving Sepsis campaign would recommend that Mr. Smith is the following initial treatment in the emergency department. Would be 1, to obtain venous access, and while doing that would be to also obtain 2 sets of blood cultures, so it's 2 sets of anaerobic cultures, run routine bloods, and also a VBG, so we could run a lactate. The Surviving Sepsis campaign would also recommend that Mr. Smith would receive 30 mL per kilo of an IV crystalloid fluid, such as normal saline, as a resuscitation dose. They would also recommend to commence combination broad spectrum IVAVs within at least 60 minutes of presenting to triage. I'm sure, as we're all very aware, it is very important not to wait for the results of our investigations before commencing treatment. So do not wait until you get a CRP or a white cell count or anything like that back. If their QSOFA is up, they have a suspected infection, start treating them as if they are septic. The other thing they recommend is to aim for a MAP of greater than 65. And to consider the early use of vasopressors to maintain the MAP above 65 if fluid resuscitation is inadequate. And the recommendation currently for vasopressors as first line is noradrenaline. Now, this is not a comprehensive step-by-step list on the treatment of sepsis and will vary from department to department, but it just merely outlines the initial emergency management needed for Mr. Smith. Here's my reference list, and thank you very much for listening to my presentation, and I look forward to having a bit of discussion with everyone in the future. Thank you.